Hello everyone, welcome back to the channel Essentials of Acute, Emergency, and Critical Care. Today we'll discuss hypokalemia, one of the most common electrolyte abnormalities encountered in emergency medicine, internal medicine, and intensive care. Although many cases are mild and asymptomatic, severe hypokalemia can cause life-threatening arrhythmias, respiratory muscle weakness, paralysis, rhabdomyolysis, and sudden cardiac death. In this video, we'll cover definition and physiology, causes of hypokalemia, clinical manifestations, ECG changes, a practical diagnostic approach, evidence-based treatment, and common pitfalls in clinical practice. Let's begin. Hypokalemia is defined as serum potassium less than 3.5 millimoles per liter. Severity can be classified as mild, 3 to 3.5 millimoles per liter, moderate, 2.5 to 2.9 millimoles per liter, and severe, less than 2.5 millimoles per liter. Remember one important physiological fact. About 98% of potassium is intracellular. Only 2% is present in extracellular fluid. Therefore, serum potassium does not accurately reflect total body potassium stores. Approximately, a decrease of 1 millimole per liter in serum potassium below normal corresponds to a total body potassium deficit of around 200 to 400 milliequivalent, although this varies depending on the underlying disease. Potassium is essential for resting membrane potential, neuromuscular function, cardiac conduction, skeletal muscle contraction, and acid-base homeostasis. Think of hypokalemia under three major mechanisms. Number 1. Decreased intake. This alone rarely causes hypokalemia because the kidneys conserve potassium efficiently. However, it contributes in patients with starvation, alcoholism, elderly patients, and malnutrition. Number 2. Intracellular shift. Total body potassium is normal. Potassium simply moves into cells. Common causes include insulin administration, beta-2 agonists like salbutamol, respiratory alkalosis, thyrotoxic periodic paralysis, refeeding syndrome, and familial periodic paralysis. These patients often respond rapidly to potassium replacement. Number 3. Potassium losses. This is the most common mechanism. Gastrointestinal losses are due to vomiting, nasogastric suction, diarrhea, villus adenoma, and laxative abuse. Although gastric fluid contains relatively little potassium, persistent vomiting causes metabolic alkalosis, which increases renal potassium wasting. Renal losses include the use of loop diuretics, thiazide diuretics, hyperaldosteronism, Cushing syndrome, renal tubular disorders such as Bartter and Gittleman syndrome, renal tubular acidosis types 1 and 2, amphotericin B, cisplatin, aminoglycosides, and magnesium deficiency. One clinical pearl. Hypomagnesemia is one of the most important causes of refractory hypokalemia. If magnesium is low, potassium replacement alone may fail. Symptoms depend on both potassium level and speed of onset. Patients may present with neuromuscular symptoms such as weakness, fatigue, muscle cramps, paralysis, and respiratory failure in severe cases. Gastrointestinal manifestations include constipation and ileus. Renal manifestations are polyuria, polydipsia, and nephrogenic diabetes insipidus. Cardiac manifestations are the most dangerous. These include ventricular arrhythmias, atrial arrhythmias, increased digoxin toxicity, and cardiac arrest. ECG abnormalities become more common when potassium falls below 3 millimoles per liter, although susceptibility varies. Typical progression includes flattened T waves, ST depression, prominent U waves, apparent QD prolongation, which is actually QU prolongation, ventricular ectopy, torsades de pointes, ventricular tachycardia, and ventricular fibrillation. Patients with heart disease, digoxin therapy, and acute coronary syndrome may develop arrhythmias even with moderate hypokalemia. Always obtain an ECG in moderate or severe hypokalemia. While evaluating hypokalemia, the first question is, why is the potassium low? Step number 1. Confirm the result. Repeat potassium if needed to exclude laboratory error. Step number 2. Review medications. Check whether patient is receiving any of these: diuretics, insulin, beta agonists, amphotericin, cisplatin, or laxatives use. Step number 3. Assess acid-base status. Associated metabolic alkalosis suggests vomiting or diuretics use, while associated metabolic acidosis suggests diarrhea or the presence of renal tubular acidosis. Step number 4. Measure urine potassium. A spot urine potassium, less than 20 millimoles per liter, favor extrarenal loss or poor intake. Greater than 20 millimoles per liter favors renal potassium wasting. Alternatively, urine potassium to creatinine ratio greater than 13 milliequivalent per gram creatinine also suggests inappropriate renal potassium loss. Step number 5. Check magnesium. Never forget this step. Persistent hypokalemia despite adequate replacement almost always warrants magnesium evaluation. Step number 6. If hypertension is present, consider primary hyperaldosteronism, especially in patients with metabolic alkalosis. Treatment depends on severity of hypokalemia, presence of symptoms, ECG changes, and ability to take oral medication. Mild hypokalemia. Oral potassium chloride is preferred and correct the underlying cause. In moderate hypokalemia, usually oral replacement is adequate. Intravenous replacement may be needed if significant symptoms or ECG changes are present or with poor oral intake. For severe hypokalemia, patients require continuous cardiac monitoring, intravenous potassium, and frequent electrolyte monitoring. Typical intravenous replacement rates in severe hypokalemia, particularly if respiratory muscle weakness or ventricular arrhythmias present, are 10 milliequivalent per hour through a peripheral vein or up to 20 milliequivalent per hour via a central line with continuous ECG monitoring. Higher infusion rates may be used only in exceptional ICU situations with intensive monitoring. Never administer potassium as an intravenous bolus. Correct magnesium. If magnesium is low, Replace magnesium first or simultaneously. Otherwise, potassium replacement may remain ineffective. Before we finish, here are 5 important take-home messages. Number 1. Always look for the cause instead of simply replacing potassium. Number 2. Check magnesium in every patient with moderate or severe hypokalemia. Number 3. Patients with ECG changes or potassium below 2.5 millimoles per liter need urgent treatment and cardiac monitoring. Number 4. Potassium chloride is preferred in most patients because chloride depletion commonly accompanies hypokalemia, particularly in metabolic alkalosis. Number 5. Avoid overcorrection. Monitor potassium every 2 to 4 hours during aggressive intravenous replacement. To summarize, hypokalemia is common but potentially fatal. A systematic approach involving assessment of potassium losses, intracellular shifts, acid-base status, urine potassium, magnesium levels, and ECG findings allows rapid diagnosis and effective management. Treat both the potassium deficit and its underlying cause to prevent recurrence and serious complications. If you found this video helpful, please like, subscribe, and share it with your colleagues. Thank you for watching, and I'll see you in the next video.